What's going on, Z-Pack? It's your boy, Z-Dog-MD. I am so freaking lonely right now because this studio is empty of Tom and Logan. They're off doing their whole family thing. And who's suffering from the acute on chronic effects of loneliness? You boy, the dog. Forget the fact that I have a full family at home who's waiting for me to come home, okay? And also, I have TK471, who... I mean, it's not, I wouldn't say we're BFFs, but we're getting there because, I mean, just look at him. It's like, he's so adorable. Anyways, guys, there are a couple things. I want to start out because we're going to talk about chronic pain today, the opioid crisis, and the backlash to the backlash to the backlash to the backlash about it. And this is an emotionally charged sort of topic. Anytime I talk about it, I will receive emails on the order of thousands, multi-paragraph, spelling out what a complete callous loser I am, or explaining how the person suffers themselves from addiction and is looking for help and understands exactly what we're talking about, or regales me with stories about how they also have been manipulated by people suffering with addiction to give them narcotics. So let's start with something that combined us all together. Okay, we can all agree on the Beatles are the greatest band in the history of greatest bands. And I say this because I was listening to Abbey Road on the car ride here from my house, and I was just like, you never give me your money. You only give me your funny paper. I mean, who writes that kind of line anymore? You know, and in the middle of negotiations, I break down. It's so perfect. Everything about that song, that album, is perfect. Now that we've established that as a fact, a baseline fact, and you know where I'm coming from, let's talk about the millions of patients who are facing pain and withdrawal as opioid prescriptions plummet. That's the article in a scientific journal called Bloomberg that I'm linking to, because again, the popular press has picked up on this whole opioid epidemic and is now going along the backlash to the backlash. All right, so let's talk about it. But first, I want to give a shout out. I got this in the mail. And speaking of chronic pain, apparently, High Z team from Carly Venjon, she says November is National Chronic Pancreatitis Awareness Month. Now, people who treated chronic pancreatitis know that this is a shitty, painful, unhappy situation, all right? It's Chronic Pancreatitis Awareness Month. I'm sending you all a silicone bracelet to wear in support of this chronic debilitating disease. I've been among the luckiest of people diagnosed because I was able to have a total pancreatectomy, that's lucky, with auto islet cell transplant. There's some luck there. I'm advocating and want to bring as much awareness as possible, and you have a loyal medical following, including myself. I hope you accept my gift to bring awareness. Yes. Now, normally, my goal with any kind of disease is to lower awareness, because usually there's too much damn awareness. But chronic pancreatitis is a tricky one, especially when it's overlaid with chronic narcotic use, chronic pain, and all the stuff that comes with that, which is the perfect segue. Look at this thing. Bam! Solid. Thank you, Carly. Perfect segue into tonight's talk. So we have put out a lot of videos about the whole drug seeker phenotype. So this is someone who suffers from addiction, who comes into the emergency department or the clinic or wherever, the pain clinic, the ER, and tries to, they display typical behavior that is designed to accomplish a couple things: get narcotics as quickly as possible and elicit sympathy from the care team so that they understand the amount of pain that they're in and the need acutely for narcotics. Now, the videos that we've made, some of them are quite sympathetic and some of them are more satire of the behavior. For example, Doc Vader did a thing where he ranted and raved about drug seekers. And of course, he uses all the stereotypes and he's an asshole because he's Doc Vader. He's our dark side, right? Our evil conscience, if you will, our id. And it's funny because people will go to his Facebook page and watch his videos and treat him like he's an actual extant creature that can respond in some compassionate way. He can't. That's not what Vader does. Vader is the voice of our angst and anger in healthcare. He gives voice to the things that many of us will have a day where we think that stuff. Some of us permanently think that, and he can just say it because no one's going to fire him because the emperor is dark side for life. And it's hilarious. They'll say things like, I have chronic disease and I hope you suffer with the same chronic disease I have so you see what it's like. And first of all, Vader's like, bitch, I was burned over 90% of my body, okay? I know chronic pain, all right? I've been digested over 1,000 years in a sarlacc's belly. That's chronic pain. I know this, okay? Second, I'm made up. I don't exist. Z-Dog may be my puppet master, but he's only using me as a voice to say the things that many healthcare professionals are thinking. And then he can do a show to talk about its nuance. Doc Vader does not have nuance. That's not who he is. The issue with this whole chronic pain situation where we've had an opioid crisis that many chronic pain people will use the term manufactured crisis, which we'll talk about. And people die left and right, young and old, all socioeconomic statuses, all races, although specifically white people because they get more narcotics for some reason. Some claim that it's because other ethnicities, Latino, African-Americans don't get their pain treated as aggressively, so there's a bias there. Whatever the reason, those are the kind of the demographics of this thing, and people are ODing and dying all over the damn place. Now, the response to that has been, well, let's see, Purdue Pharmaceuticals, Teva Pharmaceuticals, these other pharmaceutical companies, they ought to be held culpable maybe because they were pushing these highly addictive, very potent narcotics as being safe for people who had real pain. And whereas in fact they weren't. Many people did get addicted. Many people did end up overdosing. Many people did transition to street drugs such as heroin, using that as a gateway for suffering from addiction. And so we should be holding them accountable. The second thing is maybe doctors were too loose with their prescriptions and continue to be. And many of them, were running pill mills and doing nefarious, illegal things with narcotics. And then maybe patients' expectations were wrong, that their pain would just go poof if we gave them a pill, and they weren't willing to put in the work and the effort and looking at the cause of their pain and the fact that sometimes we have pain and you're going to live with some level of pain, and making it go 100% away is not only not natural, it's also dangerous. And humans have been around for millions of years without overdosing on narcotics, except in opium dens. So the U.S. using like 80% of the world's narcotics, and narcotic prescriptions going through the roof, and something like 8 million chronic disease patients on some degree of narcotics in this country, 1 million of them being on doses that would kill a horse. Is that something that we should expect in the natural demographics of the human population? And I'm going to tell you unequivocally the answer is no. So of course, now there is a backlash. Now don't forget, Joint Commission, HCAPS, all this other garbage where they're calling pain a fifth vital sign, of course, contributes to the over-narcotization of the American public and our patients. And now we have this crisis where people are dying, where even Donald Trump proclaimed it a public health crisis, whatever that means. So, of course, now the public press is coming back and saying, well, what about the patients who legitimately need narcotics when the pendulum swings the other way? Because remember, part of the reason the pendulum swung towards opioids is there was a consistent feeling among practitioners and experts that we were undertreating pain. And this could well have been the case. And so as a result, all this other stuff came in, and along with the misinformation and that infamous letter in 1980 to the New England Journal that said basically, hey, you know what? You give patients with real pain narcotics, they're unlikely to get addicted. We did a very small trial in a very small hospital with no reproducibility, and we saw that, a little case series. Boom, the genie's out of the bottle. Well, so now the question is, have we taken it too far out of the bottle? And I'll tell you this, anytime I post a video about narcotics, I get very, very furious chronic pain patients who say, and they make it instantly about them. So it doesn't matter if we're talking about a study for acute fracture pain using over-the-counter drugs versus narcotics and finding that the over-the-counter drugs are equivalent. They will immediately make it about them. But I have, this and this and this and this and this, and here's 20 paragraphs about my struggle. Well, we weren't talking about your struggle, but the fact that you've made it about you means that there's a pain point here, that there's fear, and that there's a concern. And the question is, what is the nature of that? Listen, this is the only effing place on the internet where you're going to get real talk from a freaking doctor who the only thing he has to lose is his life when a crazy patient tries to kill me. Other than that, I'm going to tell you exactly what I think. I'm going to say the things that many people won't say publicly, and you're certainly not going to see a talking head say on the news, all right? Is that a deal? All right, here we go. The first thing about this is there are all these patients with chronic pain, and the question is, they're on high doses of narcotics. Should they be? Should they be on those narcotics? Somehow a sequence of events happened. They got injured, they were on narcotics, they have a chronic disease, an autoimmune disease, etc. They find that their pain wasn't getting better, escalating doses of narcotics. Now they're on very high doses of narcotics, and they still have pain, and they still need these narcotics. And so the mere thought of the narcotics being restricted by some government interference now, as the pendulum swims the other way, by legal concerns, doctors are worried they're going to get sued if people overdose. It used to be the opposite. They'd worry that they were sued if they didn't treat pain. Or are they worried that when the drug goes away, they're going to have severe withdrawal? And I think all those things happen, and you see this really panicky desperation on the part of these patients. Now, let's say you have all the chronic disease patients. A subset of them are on high-dose narcotics, have no effing business being on those drugs. They are simply dependent on opioids. They maybe have a component of opioid hyperalgesia where the drug itself is contributing to pain. And certainly, judging by their escalating doses without actual relief, the drug isn't working. And yet we give them more and more and more and more. That is the definition of insanity. And the problem is what's happening now, and what this article is really about, and I encourage you to read it. What we've said is, we'll do, okay, blah, 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 blah. We've been taught how to prescribe. We really haven't been taught how to unprescribe. So this is what we're going to do. I'm scared of the government. I'm scared of the lawyers. I'm scared of losing my license. I'm just going to, sorry, you're not getting any more narcotics. We're just going to cut you off or start de-escalating really fast without addressing the underlying dependency, without addressing the psychological issues that go into needing these high doses of opioids. And if you don't think they exist in this subset of patients, which is a big subset, you are crazy yourself, all right? I'm going to tell you that right now. These patients, if you've worked with these patients before, you know that there is a ton of baggage that goes into these high doses of opioids. And just taking them away leads to the kind of things that happened in this article, which is this gentleman, Doug Hale, normal guy, paralegal, computer guy, ends up having some urological problems, ends up with what sounds like interstitial nephritis, chronic, interstitial cystitis, sort of this chronic pain, bladder pain, ends up going through a bunch of stuff, ultimately ends up on narcotics in escalating doses to superhuman doses of methadone, like 13 pills a day. And then finally his primary care doc says, you know what? I am not going to continue to do this because I've seen enough behavior that concerns me. I've seen enough concern that you're going to overdose, and it's not really helping you. So let's get you into detox. He does a couple detox spells, doesn't get better. The doc is desperately trying to get him into different referrals. Doesn't happen. Finally, the patient writes a suicide note that says, here it is. It's the actual suicide note. And it says, I, Douglas Hale, cannot take the chronic pain anymore. No one except my wife has helped me. The doctors are mostly puppets, trying to lower expenses and not expect any responsibility. Besides, people will die, and doctors have seen it all. So why help me? I'm expendable and no threat. This life has been taken by myself. Douglas E. Hale, Tammy Hale, that's his wife. I love you forever. Okay, that is simultaneously an incredibly sad, terrifying, and also very, to me, a sign that this gentleman needs psychiatric help and did not get it, in conjunction with the narcotic issue that was being withdrawn. And this is the problem. It's such a gray, nuanced thing. We're telling patients it's black or white. It's not. There's a lot of nuance. And if you don't get help, and guess what? The help costs a shit ton of money, and it's not often covered by insurance, and it's often not available. So Mayo Clinic, Cleveland Clinic, they have these detox programs for chronic pain patients. Now, there's plenty of detox for people who are addicts, who suffer from addiction. But there aren't a lot for people who have chronic pain who need to be weaned off these medications, and it's a huge hole because these are legitimate patients who got into the game in a legitimate way, and now you're going to tell them, no, you can't have it? Okay, that's dangerous and unsafe and crazy, and that's what we're starting to see. So yes, we are culpable for that. However, we need to address why these patients are on these drugs, because a good percentage of them shouldn't be on them anymore. It's not helping, and it's causing harm, maybe even worse pain, including psychological issues. Are we addressing the adverse childhood experience that causes them to have a different pain threshold or different problem with handling pain? Are we addressing other substance abuse, benzodiazepines and the like, right? Which often are huge problems. So all these things we're not talking about. Now you have the legitimate patients who have chronic pain who actually need the drug, who maybe go back to work because they're able to function only with the drug. Or they're on disability or whatever, but they're able to have a meaningful life because of stable doses of narcotics. Those patients we ought to be embracing and taking care of. This is a good use of this narcotic medication for them. Instead, they are terrified. And if you look at the comments on my videos, you see it. They're worried that these patients who are abusing the system are actually now reflecting on them, and they go to the emergency department and they're treated like criminals. And we all know, those of us who've worked in the emergency department, that we've been guilty of this because it's so hard to tell who's fucking lying to you and who is telling you the truth. Who has real pain and needs those drugs and is on stable doses when you have 10 minutes to see the patient, and who is dangerously manipulating you to the point where they're either selling these drugs, diverting them, or are going to overdose or misusing them. And that sucks up so much brain processor. It exhausts our little writer who's trying to do math and our elephant who's pissed off. And then we end up treating everybody with a similar brush. And that is a problem. Or we just give everyone the damn narcotics to make our day easier, which is absolutely dangerous. So this is where, we have to have compassion for the people who are suffering. We have to have compassion for the people who are suffering with addiction. We have to have compassion for the providers, right, who are being shot by patients. We've talked about this before in our Silent No More campaign, who aren't getting the narcotics they think they deserve or need, who are suffering clearly with addiction. And then you read this guy's note, and you're just like reading between the lines going, he's got paranoia, he's depressed. Who's helping him? Nobody, right? And we are so, just burned out from being manipulated all the time and trying to tease all this out, that we're also in the same boat. So that being said, the article goes on to talk about, and I'm going to read your comments, the article goes on to talk about, these 8 million Americans on the long-term opioid therapy, and, about 25% of them actually have some degree of misuse of these drugs. Okay, that's a huge number of people. The usual, blaming pharma and all of that, which is fine. But then, a lot of the chronic pain patients, they're on high doses. They aren't necessarily addicts. They're not suffering from addiction, but they're dependent. And they're not the sort that are going to go out and buy the drug on the street, and some benefit from them, but many aren't getting better or going back to work and still report high levels of pain despite big doses. And they're still at risk for overdosing because they're on such high doses. So how are we dealing with this? We don't have the resources. We don't have enough, good pain doctors, right? Like people like Kathy Travnicek, who's been on our show, who has a multimodal, multidisciplinary approach to pain that includes narcotics, but often they say, we're going to start tapering you, and we're going to do it compassionately and carefully. And if you don't like that, you need to go somewhere else. And we're going to talk, there's a good comment about that from a person who works in a pain clinic. And you look at Mayo Clinic's treatment program for chronic pain patients who are trying to get off narcotics, it costs $30,000 to $40,000. And insurance will cover some of it, but it's really, really tricky, right? And it's 3 weeks, and it's intensive, and it's got counseling and alternative treatments. Now, the problem is the experts who understand opioids are like, it's really risky to reduce dose unless you address these underlying psychological issues that come with the drug use. And it's very, very tough. So we create this monster, says Dr. Manhapra, this Yale University guy who's an addiction specialist, and we think we can just stop the opioids and that'll cure the problem, but that's naive. It really is. So people, chronic pain sufferers who are watching the show, listen, for those of you that deeply know that you have a problem and it's not helping you to use these narcotics, we need to figure out how to get you help. For those of you who need these drugs and they're helping you have a quality of life, right, we need to make sure that you're protected and that doctors are protected by prescribing the drug to you, right? That we're not at risking our license by giving narcotics. And this is the problem where the government starts to interfere and intervene in the doctor-patient relationship without knowing what the hell they're doing, that's where it becomes a problem. And I've seen that in many comments. People are worried about that. Now, there's some companies that are actually popping up that are trying to work on this problem in unique ways. So there's a company in Palo Alto. It's a telemedicine startup, which always makes me roll my eyes because I'm just like, geez, yeah, that's going to work. But it might, called Breaking Benzo, which is hilarious as a name. And they offer online psychiatry appointments and round-the-clock access to health coaches to help people quit opioids or anti-anxiety drugs like benzos. And it's available in Cali right now for $350 a month, which is still expensive. But if you consider that it could save your life, if it works, that's a bargain. They don't take insurance, and they plan to expand to 10 other states, including Ohio, West Virginia, Kentucky, these very hard-hit states. So that's one interesting option using technology that's powered by providers. But it is very difficult. Now, they go back to Mr. Hale, who progressed through all the opioids. He was saying 16 methadone pills a day, and his wife said he has having problems absorbing the medications as a result of weight loss surgery. And so who knows? It was very complicated. And it goes through the discussion of his Dr. Kornbluth, who's his primary. Now, I read this, and I actually had a lot of compassion for both sides of the story. I want you to read it and see what you think. Because having been on the side of the provider, it's tough. It's tough with these patients because you try to do what's right for them, and you never know what's going to happen. And so I actually feel for this guy if what he's saying is true and he really tried to get this guy into different specialists and get him help. It's very, very tough. So that being said, I want to read some of the comments that you guys put on the article earlier, and then I'm going to read some of your current comments. All right, Kim Harding on an earlier, when I posted the article earlier, says, a view from a 37-year-old currently fighting congenital heart defect with no cure in sight, still having surgeries, had hydrocodone in the past present for various reasons. I'm just scared. I have the best relationship with my expert team of cardiologists and general practitioners for 37 years. We have a wonderful plan in place for me. We understand that my heart isn't getting better and that pain is part of my life sometimes. Now, I'm just scared that something that may be out of my control, or their control, like government intervention, legal stuff, will cause this wonderful care plan to be tossed out due to fear of things that are happening outside the doctor-patient relationship. There is already so much the disabled and chronically ill community has to fight for lately, and this just feels like one more thing to add to the voice in our head saying your needs aren't a priority. So that is often the voice of people who suffer with chronic pain, and it's authentic and it's sincere, right? Now, the question is, Kim, I don't know if narcotics are the right answer for you. I just don't know. I'm not taking care of you. Clearly, your team of cardiologists and GPs thinks so. So why shouldn't we be able to treat you without interference? You're exactly the type of patient then that benefits from this. And you're the type of patient who's the most scared that there's going to be some blanket, pendulum swinging the other way, and you're going to be out of luck and in withdrawal and in terrible pain. Can't have that. The next comment, Deitrick Caputo. I think that a significant part of the issue is that patients who receive opioids were not warned about withdrawal symptoms. This is true. How often do you give somebody and go, oh, when you stop it, you might have withdrawal? I mean, you don't often say that in a very short visit, right? I've dealt with endometriosis, abdominal adhesions. There are periods pre-surgery where I've been on painkillers for months at a time. None of the physicians who prescribed the meds warned me about withdrawal. Also, there's a nasty second withdrawal about 6 weeks later. That's interesting. This involved, Tom Heineber literally calls me during the cast and interrupts the cast. It just shows how dialed in he is to the show, that he's calling me while I'm doing a live show. Like, that's a no-no, Tom, okay? You're fired. As it is, I don't need you guys. I'm doing it without you. Please come back soon. I miss you. Anyway, so there's a nasty second withdrawal about 6 weeks later. This involves high levels of anxiety that can have you climbing the walls and wanting to start taking again. I was lucky to be teaching a course on drugs and society when I went through my first withdrawal. Otherwise, I would have panicked. This is the thing. So if we're not teaching patients that withdrawal is a possibility and they're having those symptoms, they can conflate them with anything. Worsening of their underlying condition, all these kind of things. And opioid withdrawal is horrible. It is a horrible suffering, right? A lot of people talking about legalizing marijuana. So the other thing is many people will comment on CBD oil, marijuana. Look, if that helps you, great. If it keeps you off narcotics, great. If it doesn't come with side effects for you, fantastic. We ought to be exploring that. I'm a big proponent of exploring that. So that being said, let's look at the next comment. I'm a jail nurse, and our staff members frequently assist patients through the ugly process of opioid withdrawal. These are patients either overprescribed opioids on the outside or patients for whom prescriptions have been canceled, so they've turned to opioids on the street, including heroin. It breaks my heart. And this is the thing. So the criminal justice system is where we interface with addiction. That is insane. And I know people disagree with me. They say addiction's a choice. I say it is a choice that is also a disease. So why do we criminalize it as a user? We ought to be doing what things like Portugal, Portugal and other places have done, mostly Portugal, where they've had this really good experience legalizing these drugs and instead treating people with addiction as a disease, not a criminal offense. So that I'm a big proponent of. I'm a big decriminalize drug use, and you can criminalize drug trafficking. That's fine, but the use of it is crazy. And then we just end up with more problems, right? Heather Zimmerman says, I just can't see how this helps deter overdosing. My fear now is these honest patients have a higher risk now of turning to heroin or other street drugs. And that's exactly the thing. You can't just cut people off, right? So, comment 4, here's an interesting one, okay? Theresa Chin. These new policies are unacceptable. They are a knee-jerk reaction to a manufactured crisis. And I have too many friends going through horrible pain because they can no longer get the meds that help them. I don't take them, but if I needed to, I'd be furious that I couldn't get good, effective pain management. Okay, Theresa, I'm going to respect your comment, and then I'm going to say this. You know what makes me furious? People who call this a manufactured crisis. You clearly have not talked to a child who's been orphaned when their parents have overdosed and been found dead in the street. You have not worked in an emergency department where you've seen the amount of resources and the human tragedy and suffering that's come from opioid misuse in this country. And then you have the temerity to say, I would be furious if my pain wasn't controlled. You know what makes me furious? Seeing innocent people die from this manufactured crisis. Okay? So people who use that text are talking out of fear or talking out of the worry that government's going to intervene or that kind of thing. That's fine. What's not fine is denying that this is a serious, actual crisis and epidemic. I've had a few people tell me that who are either chronic pain patients or just uppity. And the bottom line is you're crazy if you think that. You just haven't been out there. You haven't seen it. And the Z-Pack will tell you. They will tell you by the thousands that this is not manufactured. And they're not just saying that to be dicks. They're saying that because they actually care about people. Next comment. Candycoat says, I have I think it's pronounced Kotsiomydes. Nice Greek name. I have a terminal disease, ALS, Lou Gehrig's disease. I'm tired of having to deal with all of this bullshit. I've been taking Dilaudid many years now as needed. Same dose, same doc. Why should I have to go through all of this red tape? I'm fucking dying. People with cancer and other terminal diseases should not have to go through this. My script would last 20 days if I took it according to direction. It lasts 3 months, so no, I'm not an addict. Don't tell me about your suggestions for alternative treatments because I've tried all of them. Addiction is not a disease, it's a choice. What I have is a disease and I didn't ask for it. So Candy, this is the thing. People with terminal disease, people with legitimate reasons for opioids, people at the end of their life, what the fuck? Why are we not giving them whatever they need, whenever they need it, without restriction? You know, there used to be a thing in California, I don't know if it's still the case, when I was practicing as a resident, it was called the exemption for hospice or terminal illness. And you didn't have to fill out a triplicate form for narcotics. You could write 9921, whatever the exemption code was, and get it exempted for terminal illness, assuming the person had the 6-month diagnosis, et cetera. And it made life so easy for us, especially as residents. We didn't have to get our triplicates from our attending or whatever before we had our license. And that kind of thing, the compassionate use of opioids at end of life or in terminal conditions, it's a no-brainer, right? And to see people, and I've gotten other comments from people with stage 4 breast cancer who say, I'm terrified they're going to take my narcotics away. Dude, whatever you need to control your pain, we should be giving it to you. This is a very important use of narcotics. It's, in fact, the most compassionate use I can imagine for narcotics. So that's clear. I think anyone who disagrees with that I'm going to disagree with wholeheartedly. I think that's just crazy. I mean, Emily Thompson right now says hospice patients should get whatever. I agree. Exactly, says Christina Hernandez. End-of-life care is completely different than chronic pain opioid dependence BS. So that's interesting. You can see where her elephant is, that there's a lot of manipulation in the label of chronic pain with the people who are using it as a subterfuge for addiction that make it hard for people with real chronic pain, right? Kevin Michael says, this is the biggest lose-lose scenario I've ever seen. And if you go to any comment section anywhere on the interwebs, physicians are somehow, at once, accused of both over and under prescribing opioids. Apparently, we overprescribe to everyone, but yet somehow undertreat legitimate pain. And from what I can gather, legitimate pain is pain that the person commenting has. This is absolutely true. You can see the comments. I hope you get, chronic porphyria, or I hope you get, CPRS, or I hope your child suffers with, chronic whatever, chronic pancreatitis, whatever it is. So you can see what it's like. And you're trying to take my opioids. It's like, son, I'm talking about a study that studied opioids in acute fractures. Why is this about you? You know why it's about you? Because I'm reading between the lines of your comments, and about 50% of those comments are people who are deeply dependent, if not addicted to these drugs. The drugs are not helping them, and they're terrified the drugs are going to be taken away in a rash and quick way, and they're going to go through withdrawal, which can be, lead to suicide. So rational fear for them, causing them to behave irrationally. And I agree, docs are caught in between. We were part of the problem, and now we're still part of the problem on both sides. Ruth Kavanagh. Some of this is due to the 40, 50, 60-year-old with total knee replacement, laminectomies, chronic pain that abuse the scripts provided, and their doctors won't refuse to continue to up their narcotic requests. They yell and they carry on. They threaten lawsuits. They call nonstop. They fall on purpose. They ER hop. They doctor shop. They're relentless. Eventually someone caves and they get crazy amounts of drugs. Absolutely. And these are the ones that are gaming the system. And it starts with a gateway where they're, this is why it's important, if you can avoid narcotics in the first place, it's important to try that. Without being inhumane, it's important to try that because, first of all, the placebo effect is strong. If you give someone Tylenol 1,000 plus ibuprofen, I think it was 325 or something, I forget what the dose was we talked about in the study, 400, I think it was 400, together, and you tell them it's a strong pain reliever, they're going to get that effect. And that's what the study showed, right? It was a blinded study. So, stuff works. And now, see, saying that, a bunch of chronic pain patients are going to write and say, the Tylenol never worked for me. I'm not talking about you. I'm talking about the acute fracture who we're trying to prevent getting on narcotics in the first place, okay? I know why you're trying to make it about you, because you feel voiceless, you're scared, you're worried that we're going to abandon you, because we do that. Guys, let's be honest, we do that. These patients are hard, and it's easier just to go, I'm not doing it. So yes, your concerns are valid, but we gotta attack it in a more productive way, okay? Because you're just gonna feed into the stereotype behavior. Jessica Bitchell says, I work in pain management, and while the doctors are at fault for overprescribing, the patients are also at fault. We have a policy in my office that we will not have a patient on more than 30 milligrams of morphine equivalent per day. Since hydrocodone is 1-to-1, that means no more than 30 milligrams a day. And if a patient is referred to us or self-referred and is on a higher dose, we will not schedule the patient without telling them the first thing we're going to do is to get them to back down to safe doses of the medication with help. 100% of those patients refuse an appointment because they refuse to give up their meds. We, of course, offer other options of pain relief, and we'll often try those before starting the patient on meds, which yet again makes them mad and decide not to continue care. They want a fast fix, a magic pill instead, and there's a smart way to deal with opioids, but doctors and patients both have to be willing to change. And I think that's a perfect way to wrap up the comments, because I agree. It's a nuanced thing where we're going to have to work in partnership. We don't abandon each other. We don't throw our hands up, and we need the support of government and the system, not interference and edicts, because those aren't going to work. Let's read some real-time comments here. Let's pull this up. IV Tylenol was way better for pain control after my surgery than opioids, just saying. Carrie Bennett, right? So you can start with that and see if it works. IV Tylenol is a bomb. Rachel Connerly, exactly. Can we please stop talking about this as if all chronic pain was exactly the same? Cancer pain is not migraines, is not arthritis, is not Ehlers-Danlos syndrome, is not spinal injury. Wendy Bragg. And Wendy, you made a really good comment on the article earlier that elaborated that. It was so long I couldn't read it, but I mean, I couldn't read it aloud, but I read it, and I think you're spot on. All pain is different. Pain is subjective. A lot of it is in the mind. All of it is in the mind. All of it is in the mind. That's how we process pain. So there are ways to reprocess pain, and that's why things like adverse childhood experiences, trauma, emotional stress, those kind of things contribute to our perception and management of pain. And if we ignore that, it's not saying it's all in your head, although in a technical way you're saying that. You're saying, yeah, it's all in your head, so let's figure out how to make it better, because the suffering is real. The suffering is absolutely real. Let's see. And the problem is, again, Gail Greenhagen kind of mentions that pain is subjective, so how do we know? How do we know what's going on? It's very, very tough. We have to read all these other signs, and they're not accurate in people with chronic pain. People with chronic pain don't get agitated when they have pain. Sometimes they get withdrawn. The physical signs are different. They don't get tachycardic, right? So it's very, very tough. And here, Whitney Gilliard. If you think addiction is 100% sole choice, you need to look into what adverse childhood experiences mean, what poverty is, the influence on what has impacted for addicts to go so deep into using drugs. It's sad, and our society has failed in recognizing people holistically. There has to be a better service for people who have been given the worst cards in life. Whitney Gilliard. Whitney, I tend to agree with you. My elephant agrees strongly with you from experience. I also believe it from science, which shows that free will is, in fact, an illusion. Our brain makes decisions unconsciously, and they're the product of our environment, our genetics, and our choices, while apparently under our control, are unconsciously determined, and we just have the illusion of free will. On my shopping list at amazon.com/shop/ZDoggMD is a book called Free Will by Sam Harris. I highly recommend you guys read it and understand that free will is a tricky thing, and that helps you appreciate our patients who are suffering with things like addiction, mental illness, etc. Even though it appears they made choices, and they did, those choices were influenced by everything that led up to their being who they are at that moment. And that means that if we were molecule for molecule who they are, we would have made the exact same choice. So is it really a choice? So how do you treat them punitively, or do you do things that help them make better choices and then treat them in the disease model? That's my take, all right? You can disagree with me, that's cool. That's why we have this forum, right? And it's funny, like lately, it's interesting. Like that's a fairly liberal-minded statement, but I have a lot of sort of conservative-minded statements that I make. So I really feel like I'm somehow right in the middle of this whole mess, which is a good place to be. We want to be transpartisan when we think about these problems. Think about it objectively. What's the best way to look at these things? And there may be a little bit of truth on both sides of this. Other comments, and then we're going to bounce out of here. John Jones, one thing I've never heard you address is redhead syndrome. It's real and well documented. It directly relates to how to manage these patients because pain is different. I don't know what redhead syndrome is, so maybe it has a different name that I don't understand, but I'm going to have to get educated on it. So I'm going to admit complete ignorance on that. Desiree Harms mentions Ketorolac, Toradol, as something we should use more for acute pain. I agree if people can tolerate it. This is interesting. Trisha Guy. I was on Dilaudid for CRPS, chronic regional pain syndrome, really, really excruciating pain, for almost 5 years, and just woke up one day and decided I was done. Unfortunately, stopping wasn't as easy as I'd hoped, and withdrawal was torture, but I managed it. I wish we had better options for pain treatment for those of us with chronic pain. Exactly. So that's what we're talking about. The final takeaway is, for people with chronic pain who need to be weaned off opioids, right? We need processes. We need programs like the Mayo Clinics and Cleveland Clinics that aren't that expensive, that are supported by friends and family and our social structures. We need to take away the stigma of this, and we need to talk about it. I got a message just today from someone who's an emergency medical provider who is suffering with addiction, just realized they're addicted, and the stigma is preventing them from getting help. So these are huge, huge, huge issues, all right? So that being said, guys, you can do me a favor. If you like these discussions, if you think they're helpful, hit like, that helps us, hit share. You can donate to us on patreon.com/ZDoggMD. That's great. We love that. But just hitting share is a kind of donation to us because it spreads the word and it shows that you care enough about this content to share it with your friends on Facebook and beyond. Our blog posts always live on ZDoggMD.com, or you can go to incidentreport.live to see all our videos. They live on YouTube, Facebook, and on that blog. So if you want to share it in a website form with your friends who don't use Facebook very much, you can go there. You can join our email list on my website. That way every week you get updates of everything we've done that week, which is awesome. And I don't know, you guys, I miss Tom and Logan. Look at this. There's nobody there. It's kind of sad. Even though Tom has the temerity to call me while I'm doing a show on the phone that takes the calls and interrupts the show. That's millennials, people. Anyways, I love you guys. It's apparently National Chronic Pancreatitis Awareness Month. So I was sent this by Carly Avenjon. I want to thank her for that. And we out. Peace.